big group. We're hoping to have a conversation. I mean, I think this is a challenging topic, I think. Here you go. Come on back in.
I'm here.
Okay.
So another chair.
Oh, are we out of chairs?
Here's one right here.
One in front.
Yeah, sorry.
Hey, well, I'm Lauren. I've been talking all morning, so I'm not gonna introduce myself anymore. Jane, you wanna chip in here?
I'm Jane Conrad. I'm a retired lawyer, and my commitment to palliative care stems from gratitude. My late husband was actually a patient of Lauren's, and so I'm an advocate for more people getting more palliative care sooner. So I'm here from the family and caregiver perspective. Hi, Lisa. Hi. People I've, connected with in the last 3 years and not seen in person. It's great.
So let's just get started by, I wonder how many of you all are providers, are palliative care providers? How many are palliative care providers? How many are medical people? And the rest are? Volunteers, consumers.
Hospice social worker?
Social worker, okay, I'll put you in the provider camp, probably. Yeah. So, I think this is something that we struggle with all the time. I think those of you who were in the room last night, we talked a little bit about it. We talked about the lack of clarity, the lack of systemic and standardized understanding of what this type of work is. And I wonder why we don't have a standardized definition of palliative care. Any thoughts? I mean, do you walk around sometimes just feeling not understood?
Sometimes I think it's because there's still a sense of failure in the medical world, that somebody dies, that whether, it doesn't matter where you came from, but I find that that's part of why people don't want to recommend palliative care, because it means they haven't done their best job in their personal view.
They're not done.
Yeah.
The doctors.
Yeah.
The doctor's not done. I still have more tricks up my sleeve. I can still do more things. Right. So therefore, not ready for palliative care.
We get a lot of referrals for palliative care consults from doctors, and sometimes the doctors don't tell their clients why they're coming to palliative care. So it's not clarified from the beginning on why they're coming.
Yep.
I would echo that. I think we have such a cultural fear of not even just death and dying, but even aging, illness, and I think all of those things kind of play into a tacit consent that these are things we don't talk about or think about. And I think that not everyone is trained in how to talk about them and how to be comfortable talking about those kinds of things. So even in hospice, we get folks who we're the ones to tell them, your doctor said you likely have weeks to live with this, with this illness, and it's news to them. Which of course it's not. I'm sure just different words were used, but a deep conversation wasn't had. So I just think that there's so much discomfort around not even just palliative care, but all the background topics that sort of inform it and inform how we have these discussions as a community and a society.
Are we ultimately death denying? Is that part of it? We just don't want to talk about it? Yeah.
I'm a hospice volunteer coordinator, and just a couple of days ago, a volunteer called me and said, I'm really confused. My sister-in-law, basically the doctors told her and the family that she needed to be referred for palliative care. And he said, I don't really understand why palliative care, come to find out, they were saying weeks to several months. And it really was that she was being referred to hospice.
Yeah.
But this doctor was using the word palliative care, and I wondered, was the doctor using that word because the doctor didn't want to say hospice? I don't know.
Yeah. Yeah, I'm just gonna move ahead on my slides just a little bit. So just to get this out of the way, neither of us have anything to disclose. We're supposed to say that. And our goals today, just a couple of things. Jane and I talked a lot about this, about what we wanted to accomplish during this discussion. And I think, the first thing is sort of think about the message and what message for who, right? So, what message would you like that physician to know? What does he or she need to know to make more appropriate referrals and communicate that to his or her patient? And then what do we want the patient to know? What do we want the community to know, families to know? So I think they're two different things. And then the other layer that came into discussion last night is talking to your leaders, right? Talking about the value of palliative care. And remember, the value definition is quality over, resources utilized. So we sort of drive ourselves in and say, we can save you money. That's never a comfortable place to be, right? That conversation is only for that audience, right? Only for that particular individual who can kind of fit you into their budget somewhere, right? So we had this idea that we wanted to sort of talk about the medical providers and the factors that lead to the lack of referral to palliative care services. We also wanted to talk about the patient, the family, the consumer factors that lead to a lack of acceptance of or utilization of palliative care services. We'd like to use sort of the feedback that you might have, so whereby we could start describing some strategies to help clarify these definitions of palliative care, to describe the messages, these definitions in ways that are helpful, honest, and supportive, all right? Don't scare people. So we talked a little bit about LD 1064, which, are you sick to hearing about that yet? Do you know what that is? It's something that we were able to push through, through some legislative champions and through some work at the advisory council level to create a bill that will create reimbursement for home-based palliative care services. Like, wahoo, we are one of the few states in the country to have done such a thing. There's many other states that are working on it, but California's done it. I think Colorado is on their way, Hawaii's on their way, Florida. We've got it. It's passed. Now it's cooking. It's cooking through that rate-setting, rule-making thing that the state does. It's not going to be here tomorrow. It's not going to be here for a while, but we were able to successfully pass a piece of legislation that will pay for interdisciplinary, team-based palliative care. So here's the opportunity. Who's going to refer to palliative care if they don't know what it is, right? Who's going to want palliative care if they don't know what it is? If they think it's really that hospice thing, they're not going to want it, right? And a doctor's going to say, "Oh, I'm done. All right, refer me to palliative care." That's not going to be good for the utilization of a benefit that will pay for a package of services that will support people who qualify and meet some definition of palliative care.
One of the things that I was thinking about this morning when Betty was talking was, the children with the angels, the children who are seeing angels. I think a lot of patients have some vision of their future. They can sense if they have a serious illness that it might be going there. And that was certainly, we were maybe different than most patients and families that end up in palliative care because we asked for it. But the reason we asked for it, even though I didn't really know what it was frustration in having advanced care planning discussions with other doctors. So I feel like, we pursued an advanced care planning conversation, which turned into palliative care. But I think if a lot of physicians were just willing to ask questions and listen to people about where they are, we get asked all the time, where's your pain on a scale of 1 to 10? On a scale of 1 to 10, how much is this illness affecting your quality of life? If people just listen to patients say what they're worried about, I think you could have a conversation that might lead you to this person would benefit from palliative care that's going to ease their quality of life and support them and their family. Because for me, care navigation was such a tremendous challenge. My husband had Parkinson's. It was a years-long adventure. And I think that's where, even separate from the messages and this set of messages for physicians, for administrators, for patients and families, let's listen. Who's already seeing angels? Who's already worried about what's coming? How's this going to end? And then that's where you can have what lawyers call the meeting of the minds.
But what doctors need to know is, what is it?
Right.
What is it?
Right.
That's what we need to know. That's what we need to decide. What is it? And then we need to describe it and communicate it in a way that is helpful.
Well, and I was wondering if there's already research on this, but it's almost like we're at a point that the patients could actually, that have been through these palliative care consults, could tell us what it is. And that have, most of the people that I've seen in palliative care consults have benefited from it and love it. So, what is it that they love, or what is it that they're getting out of it? And is that been done? I don't know.
Yeah, I'm sure it has, but it's a little bit mushy, right?
Yeah.
It's mushy, right? We need clarity, upfront clarity, right? We who create and deliver palliative care need clarity about what it is. Does that make sense? Yeah. Go ahead.
I've been a hospice volunteer, oh my God, I think it was 1978 I started. I was young.
Oh my goodness. You were at the beginning, you're at the cutting edge.
I actually had one of my training sessions with Bernie Siegel. We were down in Connecticut.
Yeah.
And so, it's changed a lot, but of course, not really. But one of the things that would happen early on, at least in my experience, was that we were referred to patients a lot earlier. So it was more palliative care initially.
You didn't have the word palliative care.
Exactly.
Nor, I don't mean to interrupt you, but nor did you have the reimbursement
The
from under the
Medicare
hospice
label.
label.
And it all changed with Medicare.
Right.
It all changed with Medicare.
Right.
And so you add this extra layer, and everybody is, not everybody, but there's a belief out there, I think amongst physicians and families and patients and most people, that there's a cure for everything. And we forget that we're all animals and we're gonna die.
Yeah.
And to kind of speak plain English, I find as a volunteer, I used to work with people with brain injuries, so there was a professional side. I am not a clinician, I am not a lawyer. I used to have to say that all the time. But as a volunteer, people talk to me as the woman this morning was saying when she was an aide,
Yeah.
everybody shared. And I would talk to so many nurses in the hospital, because I just hang out at the hospital with a patient, and I'd end up talking to the nurses because they really needed to talk.
Sure did.
And everybody can say whatever they want to me because it's going nowhere, and I learned a long time ago to keep my opinions to myself most of the time.
You're the second opinion.
Yeah,
I thought he was.
yeah, I gave up on that.
Yeah. But I mean, think back, that was the 1960s and 70s, and what was happening in healthcare then? Healthcare was transitioning quickly to really being able to do things, right? And it was, in fact, the 50s, 60s, and 70s, those were the decades where we transitioned our sites of death from home into the hospital, into institutionalized settings. So the hospice movement of the 70s and even early 80s was directly in response to get your technology off my body, right? So it was a very different time, right? That was very early, those early, I always say this, that, hospice was sort of evolved in people's living rooms, right, and in their hearts, right, in response to something really important. Well, we've moved on. I mean, I think somebody mentioned last night, let's look at the history. The history is important.
One of the things that happened in my world, because we were right near New York City and had a lot of friends who were artists, was AIDS. So that changed everything. So you had younger people and physicians, you know, nobody really understood the transmission early on. And there were a lot of people took on care themselves, the
Sure.
community. And there were a lot of assisted suicides.
Sure.
And it, I have to say this, it was horrific, but it was the most wholesome thing I've ever
And then what happened?
participated in.
But I mean, to move on, but
Yeah.
what happened? It became a curable, manageable illness. It's a chronic illness now. It's not, you know, it's,
Exactly.
you know, how do people with HIV die? Yes, they still die of infections, but they also die of heart disease. They die, right?
And cancer, I mean,
Cancer,
the
correct.
changes in cancer.
Correct. So I just wanted, you know, just found one of these word clouds, you know, which I didn't make my own, but I mean, you could do this, and you know, you kind of understand that for everybody in this room, there's a different definition of what might be palliative care. What I'm sensing is that there's still a lot of people who are holding on to it being very close to palliative care, right? Very close. My suggestion, my thoughts are that we have to separate ourselves. I want to just take it out of my name, you know? I'm certified in hospice and palliative medicine. I want to get it out, right? I think hospice is a slice of palliative medicine. It's a slice of palliative care, but the palliative care is this wide, hospice is this wide. That's where you got to go with it, right? You got to broaden it out.
So you think separate from hospice, is that what you're saying?
I think just take it out of there. I don't know. I mean, it's, you know.
Well,
I think
and
I just want to say
second
this. I just
Go
you know,
ahead.
sort of mentioned this last night that, you know, where did palliative care come from? Where did it come from, right? It came from Dr. Belfour Mount going to St. Christopher's Hospice, bringing it back to back to Montreal, and not having a word that really translated to the French Canadian, the word for hospice. So there was this discussion about what should it be. It's a wonderful type of care. We can't call it hospice, and hospice is a place, St. Christopher's, blah, blah, blah. So, you know, the word was to relieve suffering, to decrease the intensity, palliate, right? So it became palliative. And that's how it came, you know, it crossed into the United States, and that's the word that we sort of identified as the name of this type of care. It's palliative care. And then, you know, we just talked about this. So then we had the hospice Medicare benefit. We can pay for this type of Medicare, and it was just Medicare saying 6 months, it's all you get, just 6 months, right? They didn't say a year. Oh, and by the way, no more ventilators and no more ICUs for you, right? So it became something very, very small, but was paid for. Right. And that's an important part of our history, you know, right? And you know, I'm someone who I was doing hospice work, and then we woke up somewhere in the mid-90s and said, oh, okay, we're all going to be palliative care doctors, which is different than I'm going to find this slide, different than hospice alone, because look at this. I'll come back to these, but I just wanted to, right? This is what we started showing people, right? That back in the old days, we would just take people who were diagnosed with their cancer here and do their chemotherapy, their radiation, their blood products, their antibiotics, and then they you know, sort of get to this magic line, and then we could do this wonderful thing, pile on all these services called hospice care. Okay, and then you get some, you know, some attention to bereavement. That probably should be up there too. But anyway, in the 90s, we started talking about jeepers. I get my cancer right here, but I can still, I can get, you know, sort of parallel treatment of my suffering as I'm getting my stuff, you know. I'm getting my disease treated here, but down here I'm getting my pain, suffering. And look, as my disease is progressing, I'm getting more and more palliative care relative to hospice care. But look, we still end up here. You know, this is where we still end up. Shh, right? Don't tell anybody, right? As long as we keep throwing this up in front of people, we cannot separate hospice from palliative care, right? I mean, it's a wonderful diagram to help people understand that people move along trajectories of their illnesses, right? And needs will change based on where they are in that trajectory, right? Trajectory of illness, you guys know what that means. It means that when you get diagnosed with your heart failure, you know, it's gonna be an up and down course for years, sometimes a decade or two, you know, and you're gonna have good days and bad days in the hospital, out of the hospital. And it's very hard to know when you're gonna hit this magic line, right? Compared to somebody with cancer who has a, especially when it's not really treatable pancreatic cancer, what's gonna happen? You get your diagnosis and you're gonna get your chemotherapy. And what's the prognosis with metastatic pancreatic? 6 months, right? 6 months you're gonna hit that line. And it's easy to predict, right? So I think bottom line is that this is an easier thing to sort of think about in a disease like cancer, which has a predictable trajectory. Other diseases like heart failure, COPD, Parkinson's disease and dementia, it's much harder to fit into this sort of standardized paradigm that we think about, right? You all have seen this before. Most of you have probably seen it before. Yep.
I guess I need more clarification as far as, because I've seen so many people benefit from palliative care consults. They come in, they're not ready for hospice, but so often within weeks or months, they call us back and say, okay, we're ready for hospice. I see that as really valuable, and that we've helped them get there a little bit sooner than they might have, and that we've helped them feel better about that decision. So I guess, what do you mean separate?
I guess what I'm just trying to sort of figure out, what do we need to do? And that patient, maybe just sometimes it's dumb luck. They fall into it, right? They fall into the hospital. They fall into the hospital. They interface with the right doctor at the right time, the right social worker at the right time. There's no systemized way to make sure that patient gets the value of palliative. Every single patient, right? Every single patient with a particular disease, with a particular diagnosis, should get palliative care. How do we make that happen? And again, without clarity about what it is and who we want to serve, we get stuck, right? We get stuck. And again, I think we're still a new specialty. Just one more second. We're still a new specialty in that we have not yet standardized what palliative care looks like, right? So, when I was working up at Penn Bay, it was, me and someone else, and, working at Maine Med, there's more people wandering around, and in rural communities, sometimes it's a chaplain who's doing all the community's palliative care, right? So we haven't standardized what it looks like. You can't drive into Portland, drive into Brunswick, drive into Rockport, drive up to Bangor, and assume you're gonna get the same type of care, right? Because it depends, it's local, right? Palliative care is local, yeah. Go ahead, I'm sorry.
I just was gonna say, one of the things that has been just kind of striking me as everyone is talking is that, one of the dichotomies that I see and talk with families so often when they're talking about, is it time for hospice or not, is the idea of the word treatment. And I think, there's a huge misconception, I think, for a lot of people that palliative care is just care and it's not treatment. And I think that it does the whole, the whole world really a huge disservice. And, similarly with hospice, when someone really is at end of life, I think we have a huge language problem in many areas. I think the language of, are you fighting or are you giving up? Well, those are my only two options. Like, either I fight and suffer or I give up. Like, that's not great. But I think also just, one of the things that people do really struggle with, and that I'm not a doctor or a physician of any kind, so I can't answer that, but I would wonder if part of it too is the language of, well, are we gonna treat or are we just gonna care? And I think there's a misconception that palliative care is treatment. And in many cases, it's way, way, way more treatment. It's just all different kinds of treatment. I think there's like a real opportunity for different kind of language incorporation in that, because I feel that way very much about hospice too. When, someone says like, oh, well, I have to stop treatment for my husband, you're just gonna kill him now? I'm like, no, we're gonna treat him a lot. We're just gonna treat him for comfort instead of whatever the cause of this was.
So the fact that you have to opt for, you have to disengage from Medicare A, and put yourself in, you have to choose, right?
And so does the physician. Like, I can't imagine going to school and spending 1 billion years and $1 billion and dedicating my life to treating people, and then my option is I continue to treat them forever, or they don't get treatment. I think the whole idea of there being any dichotomy.
It's either
just,
or. It's an either or paradigm.
I think
and again, part of the message, so what's one message that we would want to emphasize? Is that you can get any type of treatment you want. You can have what you want. If you want a code, take a code. If you want an ICU bed, take it. Take it. Just tell me what you want, when you're done, tell me when you're done, right? Tell me how will I know when you're done, right? It's not
And
choice.
tell these 5 of my friends who are also gonna be here and visiting you and asking you what you want and what are your values and goals and who's important to you and, you know.
Yeah, let me just push through some of these things. You know, words matter, right? It's about words. This is about words. So we have a medical specialty and it's called hospice and palliative medicine, right? What is that? What's palliative medicine? Okay, and then we go crazy. You know,
Well,
go
you know-
subspecialist and generalist.
Let's just go back one step further, and this may be my ignorance, but why is it hospice and palliative care? Why isn't it palliative care and hospice?
Yeah, exactly. So exactly. So you know, when we get through it, you know, exactly. What is the difference between palliative medicine and palliative care? To me, hospice medicine was a word that was created by the physician community when we created a subspecialty called palliative medicine. Okay, but because of some political things that were happening, people didn't want to let go of the hospice. So I am certified in hospice and palliative medicine, right? So what I think is that this is the skill set that a physician carries into the interdisciplinary team, which is palliative care, right? Palliative care is you and you and you and you and you and you and me. All of us do palliative care, right? But the physician specialty, which is now, again, a formal ABMS, medical specialty, certified and board certified, you know, within that sanctioning thing that happened, it's palliative medicine. That's the physician skill set. And then everyone else functions within an interdisciplinary palliative care team, palliative care. Care is the care, okay? All right? Yeah.
Isn't one of the issues that hospice is Medicare reimbursed and palliative care is not at this point, other than in the state of Maine?
Yeah.
I mean, that's really an
But
underlying issue.
palliative care is covered by Medicare for if physicians and nurse practitioners.
Yeah, but that's not,
Are
doesn't
treating.
meet,
Right, it's not everybody.
doesn't meet the
but-
definition of palliative care.
And insurance companies will pay for palliative care. Right, because your definition includes these other people of social workers, nurses, chaplains, and they're not getting paid for
Right.
by Medicare and most
But
insurance.
see, hospice is very concrete in quotes,
Right.
and palliative care is not
Right.
at this point.
Yeah, so Medicare would pay for the physician to do a palliative medicine consult, right? That's what it pays for. It does not pay for care delivered by an interdisciplinary
Correct.
palliative care team. So again, I think that's confusing to people. Is that confusing to everybody? That's confusing to me. It took me a while to figure it out.
And that's part of the whole issue, I think, of looking at a medical system which is broke.
Oh, yeah. Yeah. And then throw hospice in there and forget it, because hospice in this country is a form of reimbursement where you lose your opportunity to choose, right? You don't choose, you choose nothing. You choose, again, this lovely package of services that's comfort and, you know, spirituality focused and, you know, psychosocial spiritual suffering and interventions. But again, it's a small little pocket of a whole palliative care.
And it seems as though what Angus King was talking about last night, you've already got the data to indicate it's cost effective to do palliative care. So to me, it's up to the medical community, I think, to come together and define what palliative care is
I think
concretely.
programs have to, programs that are staffed by a full comprehensive palliative care team have to decide what they are. Yeah, go ahead.
Does a patient have to choose to move into hospice? Like if they're getting the care that they want in palliative care and say they do get to end of life, but they don't want to relinquish those services that they're getting, do they have to move into a hospice
They
or
can
can
get
they
chemo.
stay in palliative care?
They don't typically get chemo
In palliative care?
in hospice care.
But no, hospice is optional. You can, it's an election, so you can elect never
But
to do
you're,
it.
you
Stay
have,
alive,
you
you're right
have
to
to elect not to get curative treatment to
To
be
get-
in
to-
hospice.
yes.
That has to be documented.
Yes.
So you're letting go of these other supports and potential cures. And, you know, to me, as you talk about evolving, that the system has evolved and this all came about historically because of the hospice movement, and at the time, palliative care was the whole spectrum. But then Medicare came in, and because they defined this benefit and cut it from when you have to give up the curative
But I
treatment.
just want to point out, palliative care had not yet been uttered in 1984 when the hospice Medicare benefit was born, okay? We had to wait another 15 years, right? Right? Palliative care wasn't spoken until probably the mid-90s, right? The hospice Medicare
So how did it come into
benefit.
existence?
Say that, I'm sorry, what's it?
I'm sorry, how did it come into, if it hasn't been spoken for that, who, not necessarily who started speaking it, but how did it get started being used as a word?
Yeah,
As a-
somewhere in the 90s, somewhere in the 90s.
How? Why?
You know what, it's probably fair to say.
What was the hole that was missing that was filled with that?
Language and reimbursement.
People
Right.
were living longer with so-called terminal diseases.
Well, I think it was more that we sort of framed it within a method of reimbursement, right? So palliative care is not hospice, but hospice is palliative care, right? Right? Again, palliative care is this broad. And in this country, we turned it into a hospice Medicare benefit that made it this long, 6 months. That's all you get, 6 months. Now you can recertify and you can be in longer, but it's 6 months, right? Where sometimes diseases go on for years, right? Years with no cure. Yep.
And it's cost effective.
Yeah.
From the legislative standpoint, they're looking at saying,
Right,
well,
but
this is cost
the
effective.
problem, and I was thinking about this last night, the problem with focusing on the fact that it saves money, palliative care saves money, is that that's not how the system works in general. You know, hospitals get paid by the thing they're providing, the care they're providing. If you're in the hospital,
Right.
that's how they make money. They're not gonna make the same amount of money if you do it the way hospice works, which is there's this bundle of services,
Correct.
X number of dollars per
Sure.
day, per month, per
It's
patient.
for different languages for different audiences.
And I was supposed to say this too, I think this is important. So we've had data that shows that hospice and palliative care, quote unquote, saves money, okay? But we woke up, I was doing palliative care at Maine Med in 2009. We woke up one day in August and realized that we were part of death panels, right? Because
You were
that,
part of what?
a death panel.
Yeah.
Because they turned that message around on us, right? Right, we weren't just, taking care of people who are suffering related to life-limiting and serious illness. We were helping them die and we were saving you a lot of money, right? That was the message that, the Affordable Care Act, what they tried to do is get this allocation, this ability to be reimbursed for advanced care planning discussions. It didn't happen at that time because Sarah Palin and her crew had it taken out because we were death panels. We were death panels, just looking to save money. We're gonna, get rid of grandma, get rid of grandpa, and we're gonna save money. So we, as a field, lost ground during that time, right? We're moving ahead, thinking we're saving money, we're making people happy, we're doing a lot of good stuff, and then bam, when that message got out there, it stopped us in our tracks. I mean, I've been to CAPSI conferences where they said, oops, we made a big mistake, right? Because that gives us this opportunity for people to consider this idea that we're somehow not invested in what's best for people, right?
But I just wanna throw in here, because you were talking earlier and before we came into the breakouts about whether palliative care is a life-limiting illness, and I understand in the opioid prescribing context why that's a concern. But so many illnesses are not as clearly life-limiting. They're affecting your quality of life, and like Parkinson's, like Alzheimer's, COPD, heart disease, lots of these go on for years. And the fact that, as Lauren said, there are a lot of cancers and illnesses that used to be life-limiting that now can be managed for much longer. All of those argue for the graph we had up earlier, where you're providing palliative care and curative treatments for a long time before it becomes clear to people that they maybe are now in the hospice category. But these are all the reasons I think that messaging is challenging, because it is one philosophy of care, palliative care, and hospice was carved out with the Medicare benefit that And those labels have made it difficult. And because it's relatively new, I think a lot of people don't know what it is and don't understand.
Right. This next bullet point too kind of confuses things sometimes, when you talk about advanced directives, when you talk about living wills, power of attorney for healthcare, post forms, because we in palliative care spend a lot of time thinking about that stuff. But is it pure palliative care to be doing, it's part of what we do. We do go through conversations, we fill out a lot of post forms perhaps, but all by itself, it's part of a continuum of expert and special, lovely care for people with humanity. Everyone should have an advanced directive. But I think it confuses the landscape, right? And I'm going to show you a slide in a little bit too that, people understand this, but they don't understand that. Go ahead, I'm sorry.
I don't know if this is something you're gonna get to, but one of the other questions I have that I'm curious on your thoughts on is that the other area that I find a lot of people, both families, patients, and then other clinicians struggle with is as we work to define what palliative care is, we're also struggling to tell them what palliative care is in different contexts, right? And so, yes, your patient would benefit from palliative care. Is this a patient who needs an inpatient palliative care consult? Is this a palliative care clinic patient? Is this a home palliative care patient? And that looks different at all these different institutions, right? A palliative care clinic, that's really different across different settings. Home palliative care, that's a different set of services. And so we're struggling not only, I think our hospitalists are really good at kind of recognizing, okay, this is a patient with a heart problem and they need outpatient cardiology follow-up after this stay. But we're a lot worse at telling people what is an inpatient palliative care concern, what is an outpatient, like where does that balance lie?
And it's this, again, we're still babies, right? So, 10 years ago, what goes 10 years ago, 10, 12 years ago, the only place you could get palliative care was in a hospital, right? That's the only place you could get it, right? And all the early data about cost savings and it's all hospitalized patients. Well, 2010, the lung cancer article came out and we started thinking about continuity, but for the longest time it was only in a hospital. So, and in Maine, we're going to hear this afternoon when Cord does his presentation about the surveys 2016 to 2022. I don't know what it shows yet, but we had very little outpatient palliative care in 2016. The little bit that your husband got was just because she's fierce, she's persistent. She wouldn't have gotten it any other way, right? Informed, advocative, family members will find it, but the system doesn't just deliver it. And again, I think it's that lack of clarity. So palliative, you could look at the diagnosis, it could be provided anywhere, any place, any disease, right? Anywhere, anybody. If you broke your leg today, you'd want palliative care, right? Yeah.
So wouldn't the primary focus then be on palliative care focusing on a better quality of care where you're, say in my case, because I work in oncology, my oncologist would be working on longevity where my palliative care provider would be working on my quality, hand in hand.
Yeah, that's right. You probably have heard this before, just, so I go into my palliative care consults really not thinking about death too much, I don't think about it, I don't care. We're all gonna die, I'm gonna die. So my patient with stage 3, lung cancer is gonna die, but guess what, me too. Who's gonna die first? I have no idea. And I would really literally start my conversations like that, like, I don't know, we're all gonna die. We're gonna talk here, spend this time talking about your death, but I'm gonna go out and get hit by a truck, So that starts the place where it's not about death. We don't talk about death, I don't. As things evolve and as things change, you're gonna sort of broaden the conversation maybe, but that very first conversation where you're introducing palliative care, let's just live, right? Let's live well today, right? Whatever it takes. Let's do some planning about the future, but let's just live today, right?
But one of the huge challenges for patients and families is how siloed healthcare is. So like you said, you're in an oncology practice, but a lot of people have lots of different problems come up when they're seriously ill. And it's so hard if it's like you're like a ping pong ball, you're going to this person and that person and you're having GI trouble, now you're supposed to go see somebody else. And I think a real selling point of palliative care is the holistic, person-centered nature of it. that you're gonna have somebody who's looking at the whole picture and helping you navigate different specialties, different symptoms, different treatments, and not, it's so hard when you have somebody who's seriously ill and you're schlepping them around, to doctors in a big state like Maine, where it's 2 hours here, 2 hours there. And it was before telehealth that my husband died, but, the fact that you can have somebody help you navigate that is huge. So I think it's a real selling point.
Well, yeah, it's only a selling point though if you've got it, if you've got the staffing to do it.
But
I mean, I
if
think
we're
that was-
talking about the message, to me,
Yeah,
a big message
I think that
is.
what the problem sometimes is for some of our small programs is, I can promise you, I will always be there. I'm gonna support the best possible quality of life. I'm gonna manage every complication. I'm gonna be there and I'm gonna fail because I can't do it alone. I think that, the last thing I wanna do is disappoint, right, and fall short, because that's not gonna help my field. So depending on where you're working, you may be defining your program in a little bit more of a narrow scope. Is that what you were sort of thinking, watching your head?
Yeah, so I think the hospital I worked in, we were all physically on the same site. So a lot of times I'd be able to see my patients with the oncologist.
Yeah.
And the patients would reach out and say, please come and help me.
Yeah.
Because honestly, they felt like they needed help.
Right.
In saying, I don't want to do this anymore. And half the time, you were sitting there trying to tell the oncologist.
So this was an outpatient setting?
In the
So
outpatient
this
setting.
is, that goes back to the model too,
Yeah.
right? It's a co-located model of palliative care.
Exactly, and so when you
Embedded
don't
right
have
within-
that,
right.
and then the other part is that as time went on and we don't have that as much, I think we just have to enable the patients to say, this is what you have a right to ask for, demand.
Right.
And these are the things you need to say to your doctor that's important to you. And if they don't hear us, then come back and we'll help. But we have to have the patients know that they have a right to demand this.
Yeah, I hope.
And I think telling people that you're giving them control is another big positive message. Because, especially as baby boomers who are used to having a lot of control get older and they want a lot of information, they know how to Google everything. I think that's a big pitch that we should make, is you're gonna have more control over your care and more conversations about what you're caring and what you don't want. And just like you said, when you're on this roller coaster of in and out of the hospital, treatments and torture, someone needs to tell you, you can get off. And we'll be here for you when you're done.
I'm wondering if one of the problems is you're looking for clarity, but our medical system has so many silos, it's so hard to have clarity. And are you asking for palliative care to be another silo? And if so, I don't know if that's the model we want,
Well, I've worked in a palliative care silo before, it's terrible.
Yeah, and on your graph, how do you interchange with the PCPs and the oncologists? And so those other doctors,
Yeah, so go back to my first bullet point. I feel like I'm failing you here because I can't get out my my bullet points. So, within the skill set of palliative medicine, we recognize that there's not enough palliative medicine doctors out there to fulfill all the needs. So we've spent some time thinking about, so you know what, within each and every one of us, there are palliative care skills, right? Within each doctor, within each nurse practitioner, within each nurse, within each social worker, there are, skills that are, listening skills, self-awareness skills, empathic skills. We have the ability to do that. And for, don't call me for that simple transition to hospice for a patient that you've known for 40 years. You don't need me. They need you, right? Right. So, but that's palliative care, right? That's primary palliative care, right? Call me for the hard one. Call me for the patient with substance abuse disorder, pain, with a dysfunctional family, and who's in denial. Call me for that one, right? Because those are the harder ones, right? Right. You're right.
You're presuming people have those skills though. I mean, we just
Well, I
heard,
can't-
and
I
my
can't-
experience
this is-
was, oh, my beeper's going
Yeah, but
off.
I can't fix that right
Advanced
now.
care.
I can't fix it. But it's talking about where we need to go, right?
I think we have a tool, and you mentioned it early on, Jay, is to again, it's not a panacea, far from it, is the only form I've ever seen from the state of Maine, and I used to do public policy, is the advanced directive. It's a really good form coming from the state. It's not perfect. But if you had everybody, healthy, not healthy, doctors, clinicians, everybody fill one out, and they're not legally binding, you can change them. It asks the questions about what you want for treatment.
Right. The problem is, I'm just gonna stop you right there. Where are they though? Where are these advanced directives? They're in somebody's sock drawer, or they're in some attorney's office, right?
And so to come up with a practice of, I mean, I added a letter, an addendum that I sent to the hospital when COVID started. So obviously, but to have them in the sock drawer, have it as a standard practice, make your doctor, your PCP, make sure they have it in their file. And I know some of them ask and some of them don't.
You know what, we could spend a whole hour talking about the advanced care planning process, and I don't really want to do that, but
I think
advanced,
it's a tool though.
well, advanced directives alone don't work.
No, and they don't, but they introduce the subject. And they introduce the subject not only to the patient and their family, but also to the clinicians.
Yeah.
Make them fill it out, whether they hand it
Can I just break in here? In that the problem with an advanced directive is that it's very theoretical. You're sitting down at a time where all is good, and the most important thing that comes out of an advanced directive, yes and no. The most is what? It's the designation of a healthcare power of attorney. Okay, because when things go south, not north when we're doing well, when things go south, I want to know who this patient is and what are their goals, values, wishes. It says that they would never want to be on a ventilator, or it says that they're fighters, they want to do everything. But what about, and then you describe the clinical situation. All right, an advanced directive, a good conversation is helpful, but the most important thing that happens in an advanced directive is the identification of someone they trust who can help me help them create a plan of care, because that's the post form, right? That's
Yeah,
right?
and I can see that strategy, but I think people need to think about it before, whether they stick to it or not.
And again, I think, the purpose of this, we're talking about language here, right?
And that's
That's language. So I'm just gonna jump around here because I'm can't seem to, I'm not in a straight line today, I'm sorry.
It's not a subject that's a straight line.
So here's some interesting thing. There's an art, I'm sorry I don't have the reference on here. If you want the reference, I can. So they did, if you took a look at all the articles that are out there regarding people's understanding of these concepts, right, from advanced care planning to hospice to palliative care, this is sort of what was found. So 80 to 90% of people report awareness of advanced care planning, of having an advanced directive, but only 10 to 41%, depending on the study they were looking at, actually had one, right? So everyone says, yay, go get your advanced directive, but very few people do, right? And again, when they do, they're not always readily available to the clinician at the bedside, the clinician in the ED, right? So, as these same people, what do you know about palliative care? 66 to 71% have no idea, right? Have no idea what palliative care is. A full, 2/3 of people wandering around the street have no idea what we're talking about right here, right? And of those that do, they conflate it with hospice care, end-of-life care, right? And I know what that is. It's that thing towards the end of life, right? So, that's not necessarily a helpful thing to me, right? The fact that they know what palliative care is, but it's wrong. 86%, this little piece of information. Once you say, hey, you know what, if you are really sick, getting close to the end of, living with a life-limiting illness, and you were struggling with pain and dyspnea, and you were worried about the future, how would it sound to have an additional layer of support? How would it be to have someone help you with your pain? 95% say, sure, sign me up, right? So again, that kind of gets to that messaging thing, what it is, extra layer of support, that's the words that we use a lot of times, right? Extra layer of support in the face of some kind of illness. Would you like it, guys? Go ahead.
I've always found it interesting. I've been a volunteer for 14, 15 years now. And I've always found it interesting that you never hear anybody say, I wish I hadn't done this. you hear them say, I wish I'd done it sooner.
Yes.
And it's so important that the message does get out there. And it's frustrating because, you know, you're talking to a wife, a daughter, a mother, a grandparent, whatever, and you're saying, you know what, why don't you be the wife? Why don't you be the son? And let this other person come in and take this responsibility off your shoulders and help you to be able to be more in the moment, help you guys to be able to make the most of the time that's left. But they always say, I wish I'd known sooner.
For hospice care?
Yes,
Of
hospice.
course, yeah, of course.
Yeah.
But really both. I mean, I certainly would
Yeah.
have said that with palliative care, that I certainly wish we had accessed it sooner.
So again, this is, I'm sorry, I'm really rude today, I'm so sorry. You know, we used to say this, you know, we used to have these conversations, Jane, you remember, you know, so why don't those doctors refer to palliative care? Why don't they refer? Why don't they refer? Why don't they refer? Because we have not yet built it, right? Right, so we've been in our hospitals, in our ivory towers, doing lots of palliative care, and then gosh darn it, why don't they get palliative care when they go home? Because it doesn't exist, right? It's moving, but that's kind of the reality, right? You can't refer to something that doesn't exist.
I wonder what the survey would be if you did to physicians about their awareness of palliative care.
Well, let's see. Yeah, oops.
Physicians are actually, they're worse than the general public.
Well,
You know, I
getting
mean,
at.
they're more resistant to making referrals than the general public is resistant to accessing
I'm
palliative.
sorry, I just had to share this, my favorite, this is my favorite. So I can remember, you know, walking the hospital with my name tag on, palliative care, I'd walk into an elevator, say hello to everybody, and people would kind of go. I mean, this is what we struggle with. People think that we are very, very close to the end of life. That's what people think, and as I said before, that's not good for us. Go
I
ahead.
mean, I think a lot of it starts in medical school, because if you talk about educating primary care physician or specialists now, they don't have time. I mean, they're going from patient to patient, they just don't have time.
Yeah.
Well, and I think, as was said earlier, you're really expecting a lot from physicians who've been trained to be fighters, to,
Right.
you know, on
Absolutely.
behalf of patients, to
Absolutely.
say that at some point they
failed.
recognize either that it's time, they can't fight this anymore, and now
Yeah.
a lot of physicians don't think of just communication or being there and listening as healthcare.
Right.
But that is healthcare.
Where it actually would help them.
Yes, right.
So I just want to mention, you know, there's a book, Death Foretold, and this physician, palliative care physician, he's also a sociologist, Chris Christakis, came out like in the late 1990s. He wrote a fascinating book about prognostication, about the act of prognostication by physicians. And physicians hate to do that, you know, they absolutely hate it. I don't think it's as bad as it used to be, but especially in those early days, you know, so doc, how much time do I have? I don't know. I never make predictions, you know, never make predictions. And it turned out that there was some research that certainly they were not trained to give up. We weren't trained in how to prognosticate. And also they were afraid, right? They were afraid. They were always afraid to be wrong, right? You know,
Afraid to be right.
Afraid to, that's what I wrote here, right, they're afraid to be right and they're afraid to be wrong. If they're, you know, if I predict that somebody's gonna, you know, oh gosh, you know, I don't think you have more than 3 months, you know, then the goal of that patient is to outlive their doctor, you know, I mean, you know.
Whatever works.
Right. Or if they under prognosticate, you know, and then the patient lives, they're worried about what their peers will think. They think that they'll lose trust among the family members. So it's not something that many of our older physicians especially have a great deal of comfort with, because they just didn't learn how to do it. And then of course, it is a skill set, right? That's why it's a medical specialty. Having conversations and, you know, is a skill set that takes attention to details, to requirements, and then you have to practice it. I think it's important to also talk about the physician community is not always clear about who's appropriate. They tend to think that it is the patient who's 2 steps, short of hospice. That's what it is. Maybe you just need a little more time to figure it out. That's what palliative care is for, right? And how many consults do you get that are that way? Just that, right? When I used to sort of try to collect my data and my programs, it was like a third. A third of my patients that we got referred asked to see were for just that transition to hospice, because we do it so well. Right? You do it so well, right? So
I used to find that we would get a consult in the SICU, very rarely,
Yeah.
and go out of our way to tell the surgeon, don't worry, we're just gonna go in there and offer our support, and we're not gonna change your plan, and you walk in, and the first thing out of that family's mouth is, why are we torturing my son like this? Or I wanna stop, and no one will let us stop. So after you've gone out of your way to say, we're not about the end of life, you are, because no one's talked about that.
Right. And again, I think we are, you just asked about a physician. I read this interesting article comparing home-based palliative care programs in the mid-2000s. And it was carried out by a PHO, or one of those organizations where everything is contained structurally. And they had, criteria, they had a full team, everyone went at home, and it was like fabulous. It was great. And the outcomes were good. 15 years later, in the more recent years, they repeated it, but the structure, the organizational structure was more within an ACO, where they add things like criteria, and they look at algorithms, who are your high utilizers, and it failed miserably. The physicians no longer knew what palliative care was. They couldn't quite fit it into an algorithm. So I thought that was interesting and they had to stop the study because they couldn't get enough patients enrolled. So this idea that we can control who gets referred if we can be clear about who we want, who's appropriate for palliative care. Here's the Grim Reaper again. And there's this woman sitting in bed. I keep telling you, it's a chronic illness, right?
And I feel like a message that crosses both patients and families and the professional community as far as who's appropriate is when your symptoms become so troublesome that it's a burden for the patient and for the family. When people are really starting to struggle, and I feel like if physicians are listening to their patients, whether they're cardiologists or oncologists or neurologists, listening for how troublesome is this to you, that is a good time to bring on another teammate, the palliative care team, to help identify ways in which we can support you, because you've got a ways to go with this illness and we want to prop you up.
So I was interested in Dr. Van Kirk's discussion this morning where he asked the question, so is Crohn's disease an appropriate diagnosis for palliative care? No. Is
It depends on the impact it has on your life and the
Quality of life.
those.
Right.
Wouldn't that be true of any illness? I mean,
That's what I'm saying here. You have a
yeah.
serious illness of an undisclosed nature. That's confusing as heck, right? We're all gonna die. Let's all get palliative care tomorrow, So I think that, again, that lack of clarity is really challenging, right? So, and then I've heard that sometimes people like the words serious illness, but they don't like the word advanced illness, right? Right.
That's too scary.
They don't like the word life-limiting illness. So we are for patients with serious illness, right? Life-limiting, you're turning on the light again, like, ooh, we're going to hospice, right?
But even serious is tricky because diabetes, there are a number of illnesses that are serious, but if you're managing it, it's not bothering you every day.
Right.
Until it's advanced, and that's why I feel like troublesome is kind of a good word when it's really affecting more things than you can cope with easily.
But that's not clear.
No, it's not
I
clear.
want clarity.
I'm visual, so I need something, and I need you to help me with something. So in that scenario, they would maybe say if it's diabetes, they're gonna go to this doctor. If it's Parkinson's disease, they go to a neurologist. Where does it sounds like what you're wanting is palliative care to be a bigger umbrella. I guess show me a little bit about how you see that.
I think that if you have an illness that's never, ever, ever, ever gonna go away, and you are sad, having trouble coping, have pain, have worries about your future and your family, you could probably be appropriate for palliative care, right? So, but what form does that take? Is it a primary level of palliative care that a social worker can help in a primary care office? Or is it something that requires a very expensive, highly trained, interdisciplinary palliative care team? I mean,
And sometimes it might just mean introducing that patient to the fact that this exists, and you may not need us now.
right,
But 3 years from now, you might need us, and then you might need us again
Right.
5 years
And
after
who do you
that.
need on the palliative care team? Do you know, I mean, so many times in my palliative care work, it's the social worker and the chaplain, right? Once we get through the goals of care and I understand what this patient wants and pain is good and it's comfortable, it's in the psychosocial and spiritual domain, right? That's where the suffering is, right?
So I think of it as being somebody on your medical team, depending on where you are in the trajectory of your illness. But, and my goal is to have it be provided sooner rather than 5 minutes before the catastrophe or in the middle of the catastrophe. So when you still have your cardiologist, your neurologist, your oncologist helping you treat the symptoms, that's a good time to have a palliative care team, member of your medical team, helping you navigate the symptoms that you have. And I think, at least in my experience, it became clearer and clearer that the interventions from neurology were getting to, we're tweaking medicines was doing nothing. We're really in the winding down phase and having those conversations to help you make the transition.
And so what, did you stop seeing the neurologist at that point?
It tapers off. If you feel like it's pointless, you're not making appointments.
Well, I think it depends on the neurologist. Sometimes neurologists want to see.
That's right.
It's up to the doctor, right? Right, we can't generalize. Some people, I'm sorry, this is not what I'm good at, go to Lauren, whatever. So I just want to, we don't have much time, so you see some programs, okay, we talked about this before, there's hospice care, and then we call it palliative care. They're so stuck together, people just can't separate us, so let's do something else. Let's give ourselves another name. Change it from palliative care to supportive care. Does that change anything with regard to your messaging, I wonder?
A lot.
Yeah, this came up, were you here last night? Were you here, whoever said that? Yeah, I think one of the doctors.
Becca was saying you can
so-
call it whatever you want.
Right, what we should do is change the behavior, right? So if you're gonna come to supportive, do supportive care, meaning separate yourself from hospice and find that patient as early as you can and offer supportive types of interventions, right? Not necessarily the ones that are confused with palliative/hospice. I mean, I don't know if this is true. Some programs have done this. My feeling is that unless you change those behaviors, unless you change the practices, patients will figure it out, right? It's just another word. I know where this is going, right? I know, we're going to hospice, you can call it whatever you want. So again, I think it's just a sort of a strategy that some programs have used. And I just threw this one in here because if you Google palliative care pictures, you're always gonna get hands. Right? You're always gonna get the hands. I can't tell you the number of times I've put together presentations and I've used hands. What the data shows is people don't want to see any hands. Don't show me hands.
And I don't want to think that somebody's in a hospital gown. To me, ideally, maybe you're getting it
Well, I just
first
want
in
to
the
finish this
hospital.
point. What it gets to is the fact that it's not hand-holding. It's active, aggressive care to manage suffering, right? And when this is like soft and fuzzy and mushy, right? I don't like soft, fuzzy and mushy. If I'm trying to communicate that my program has value for patients who are living with serious illness, irregardless of when they die, right? So anyway, just don't use
It's
hands.
also old hands. They're not, as we heard this morning, it's all ages, all illnesses.
Yeah, so these are silly slides. I mean, I think there's some points in them that we tried to sort of pull some things out. I don't know if it really flowed, but there are some people who are studying this, and supposedly the messaging you should use. I think you need to decide on language for type of disease, right? I think serious illness is what people are recommending, not advanced. Woo, that's scary. Woo, I'm going fast. Or life-limiting, like, Well, I think, focusing on that word, talking about the benefits, right? Don't say things like, we're not hospice. So when I think Becca said this last night, the minute you say it's not hospice, in people's minds it becomes hospice, right? And present it as a choice, we're not gonna live forever, I'm not gonna live forever, how do you want this to go, You can, there's so many different ways that people can do this. You can go, you can try hospitalization one more time, you can try one more ICU care, ICU round without the ventilator, you can try avoiding the ICU, try just antibiotics at home. There's a lot of different ways we can do this. You tell me what's most important to you. Oh, I hear this, being home is most important to you. Okay, let's work on that, okay? We'll do everything we can to keep you comfortable, treat you as completely and aggressively as we can, but we're gonna keep you at home. So again, it's choice, right? So stressing that it is about your choice. What do you want? Using positive stories, the stories that you have, the ones, I don't know who said it, I hear people say, I wish I had this earlier. So, when you're talking to your leadership and you want more staff, talk about the stories, like dialogue, I don't know what that means. Call to action, talk with someone, a clinician. I've done this many times with, patients, families not really sure if they were ready for palliative care, but sit down and talk to them about it, like, what are you not ready for, It's not happening today. But, Sarah Dwelly used to have this Snoopy picture in her, one of the nurses that I worked with, I think it was Charlie Brown saying something like, one day I'm gonna die, right? One day I'm gonna die. And then, Snoopy in his little bubble saying, but every other day you're not gonna die, So just focusing on the positives, sometimes I think, what you're trying to do is just give yourself some time to figure out what the patient really wants to know, wants to hear, and again, just keep it positive. We're gonna live well today, we're gonna be strong today, and whatever happens, I'll be there. Right? That's sort of the essence of it. So it's really hard work to do when you don't have that full team, though. When you make promises that I will be there, I can manage all your pain, I can do everything, but I'm the only practitioner in a program that's not going to work.
So unlike hospice, the services are bundled with a per diem. Are you hoping in palliative care that each discipline will be able to bill? Is that?
No, I think what you hear coming from the feds nationally is that there's just build a palliative care benefit that looks like the hospice benefit. Yep. Similar to that, bundled, right? That's what the benefit in our main care benefit is. What we're sort of suggesting that it look like. So it's going to be like a per member per month reimbursement for palliative care services.
Can I just say that with hospice volunteers at Hancock County and Ellsworth, our volunteers are now serving more, or we're getting referrals from our palliative care teams around. Not when they think they're gonna live another 5 years, because our volunteers are not signing up for that. But when the palliative care docs think maybe in the next year they're gonna be hospice eligible. And so for those licensed independent hospice organizations, I think that can be really beneficial.
I love that idea.
Yes.
I love it.
Yeah, I would say probably 40% of our caseload is palliative care patients.
Because what happened, these poor caregivers, oh my God, I got another year at this. Oh good, I'm gonna have them for another year. Like, oh my God, I'm gonna have them for another year. And they get burnt out, right?
Yeah.
Right? Right? So supporting the caregiver is a lot of what you're doing with those volunteer hours.
Absolutely. Yeah, and being there to just talk with them about.
Correct.
And, whatever is going on.
I love that idea.
Yeah.
I don't think we do enough of it.
Yeah.
I just don't think we do enough of it.
Yeah.
Yeah. But you're right, I think it's Maine is kind of funny that way, where we've got these, we can license volunteer programs, like, oh, we must be crazy. Nobody else does it.
Yeah.
I think Idaho used to do it. But, so,
We're fortunate in that regard.
Yeah, it's great. No, there's no limits. No limits what you can do.
Yeah, absolutely. Yeah. Can you tell me the name of that book that you mentioned earlier?
Death Foretold.
Thank you.
It's by Nicholas Christakis. Okay. I'm sorry, guys, for this time went real quick. We gotta make it so easy.
Thank you.
I don't have my contact information. If there's any questions that you all have, you can find me.
Nice to meet you.